Mechanical ventilation was started in the 1950s during polio epidemic. Since then, it saved thousands of lives. More sophisticated ventilators were made in the last few decades. However, more lives were saved with the knowledge that low tidal volume ventilation is less harmful, and subsequently the ProSaver trial showed the mortality can be reduced to half by using prone ventilation in a select group of patients. We are going to demonstrate a proning and deproning session in the next few minutes. This is a patient with refractory hypoxemic respiratory failure with very high pressure. PEEP has been set at 12, could have been higher as well, but he's on 100% oxygen for 2 hours following intubation, and therefore proning is being planned. So we are here to prone this patient who is not doing well on 100% oxygen and is quite difficult to ventilate as well. And therefore, according to protocol, with the mortality benefit that proning shows, we will prone this patient safely. And the leader of this session will be Vipul, who will go through the steps first, and then we'll prone the patient and make sure everything, all the tubes and all the lines are safe and secured, and we achieve a good result from the exercise. So Vipul?
Yeah, hello. So make sure you have checklist open with you before starting proning session.
During this time, they will ensure all team members are allocated roles and check for any contraindications, airway trolley to be kept nearby, and endotracheal tube to be secured, NG tube to be stopped, and NG tube to be aspirated. Enough line slack also is to be ensured, pressure areas to be taken care of. Team members will ensure daily hygiene including mouth care or washing are completed. This patient was not absorbing well, therefore he was on a free drainage through his NG tube, but often patients will be on the feeding, continuous feeding, and it can be again safely detached after aspiration. So are you all ready? We are all happy with what we have got.
Okay.
So we will go with Vipul's call.
So we have disconnected all the monitoring which we need to.
Yeah.
And then we need to keep 2 pillows, one on the patient's chest and one on patient's pelvis, just to make sure that abdomen is free.
And there is one point to consider here, that if the abdomen is large in very centrally obese patients, sometimes you may need more than one pillow to keep the abdomen free. This patient is quite lean and thin, and therefore one pillow is okay to keep the abdominal gut completely free from pressure when he's prone. But sometimes we get centrally obese patients, and you might have to add more pillows there.
Okay, after keeping pillows, we put a bed sheet on a patient, and then between 2 bed sheets, we just make a quick, well packed thing.
So we are rolling the edges of the sheets to make sure that we have got good hold of the patient and all the pillows, so that nothing moves. And we are making sure that everything else is secure and safe, and the patient is still stable, as stable as he can be, and the airway person has to be happy. So Vipul?
Yeah, so I'll take care of center line and endotracheal tube, and on my call then we will start rolling. The plan is, if the center line is on the right side, the plan is to keep the center line always on the up side. So we'll roll the patient towards the patient's right side, and then we will slide the patient on the right side, and then we'll roll the patient.
So that the line is always on the top and it's not getting entangled with the neck or the head, which then becomes problematic.
Okay.
At this point, the team has ensured that there are a minimum of 5 people. Ventilator settings are appropriate and FiO2 is set at 100%. The patient is cardiovascularly stable. He has adequate sedation and muscle relaxation. Pillows are positioned correctly. Infusion pumps can be on one side but can also be on both sides as long as there is enough slack.
So we already, on a count of 3, then we slide towards patient's right. 1, 2, and slide. And ready for roll?
And we have to move our arms so that we can roll properly. Okay.
So 1, 2, and roll. And then 1, 2, and slide.
Okay, and let's put some ECG dots very quickly on the patient's back so that we can attach them to the monitoring.
Right is somewhere out here.
So there are two ways you can keep the head and neck position. If you have stiff neck, then it's probably not good to keep it on the lateral side, so you have to be kept as a straight. If you have a long and flexible neck, then you can keep the head on one side, on either side.
This patient has a very flexible neck, so we can actually put a pillow underneath, and that has to be done quite safely so that the pillow does not dislodge anything. And I have just inserted the pillow in between the bed and the head, and he's quite well secured. And
we have a safe airway, then we can.
Are you happy that the line is not hindered?
Yep.
The tube is coming out quite nicely.
There's no
and-
kinking, nothing.
And we can now attach the arterial line as well during this time. And his rhythm is quite stable. And on this side, let's attach. And once you attach the outline, it's always good to re-zero that as well, which we can always do quite easily. And with this, Vipul, do you have to mention anything about the arm position?
So we can put both the arms up if the neck is neutral, but now the head is on the one side, so we keep it as a swimmer position. So head faces away from the upcoming arm.
If he is looking to his right now, his arm
So
can be
left arm can come up.
can be elevated.
That's it.
And then we need to move the head, turn the head to the other side every 4 hours. And once that is done, we have to change the arm position accordingly. This arm then comes up and that arm goes down. Now, sometimes we do have a situation when the neck is very rigid and not flexible at all, and we just have to make sure that there is a strategy for that as well, in which case you can't keep the head like that. Then what we do is we move the patient slightly outside the mattress and keep the head in neutral position. So Vipul, do you want to show that, please?
Yep. Keep the arm back.
So I'm not going to touch that pillow until you have grabbed the airway.
Yep.
You happy?
All right, I'm happy.
Okay. So what do you want us to do, Vipul?
So we need to, someone need to grab the mattress. So that
Because otherwise the mattress would slide with the patient. So we have got the mattress being stabilized on the foot end.
and then we have to drag the patient off the mattress, drag the patient's head off the mattress so that we get some space to keep some support under the patient's head and keep the patient's head neutral. Alright? So on the count of 3, we drag the patient upwards toward me. 1, 2, and 3.
Okay. I'm going to insert that pillow underneath, and often for this we have to fold the pillow like this to make it thicker. And here we have.
So in that way we can keep the head neutral, taking care of pressure areas.
Now that's quite nice. He's only got his forehead supported by the pillow. Sometimes we have to, depending on the size of the patient, we have to move the mattress downward first and then get the patient upwards, depending on the size and the space you have got. Here we are okay, but there are often situations where we move both the patient and mattress together downwards and then get the patient up to make the space. Here we are quite happy with it. So that concludes the proning part of the exercise. This demonstration has been done without specialist equipment like head frames, and also without too much movement of the equipment, as during the pandemic units with various resources and size may have to implement this exercise, and it may not be possible for them to have all specialist equipment or large space during the procedure. now that we have got improvement on oxygenation, we are happy that we can give him a trial on his back, and it's been 16 hours as well, and therefore we have to now safely supine him, and Vipul again will lead us on that.
So again, like as we proned him, we need to deprone him now. So we need to start with our disconnection of monitoring. So we can disconnect ECG and arterial line, keep the end-tidal CO2 and saturation probe connected. And again, take care of catheter to stay in the center and between both the legs. If arms are up, then you have to keep the arms both on the side of the patient. And
so the patient is very well tucked in and within his bed sheets, and Vipul is taking care of the tube. He has held the tube quite securely. Tube is on the right side of the patient, and we always want to keep the tube at the top.
Yep.
So Vipul, which side do you want the patient to come in?
So I'll ask you to drag the patient towards you and then roll the patient.
Okay, so he comes towards me first, towards this side,
Yep.
and because line is on this side, and then we roll.
All
On
right.
your call.
1, 2, and slide. Very steady and roll.
And then you
Right. 1, 2, and 3.
put him on midline. Now very quickly put his ECG dots back on, move the pillows there, and at this time it is always good to check the pressure areas on his chest and on the abdomen. Make sure that this is all safe. We will have a quick look at it, and also on the pressure areas on the leg completely. Make sure there is no pressure store coming. Usually it's not the case if we put the pillows well in place and take care of the pressure area, and you often have to tape the eyes as well. Okay, are you happy, Vipul, with your head position?
Yes, I am.
His head is slightly on the outside of the mattress, so we can slide him downwards.
Sliding downwards. Okay, 1, 2, and down.
If you tell me when, I will insert the pillow underneath.
2 pins and 2.
So we must clear the central line and light tubings from the underneath him. So if you hold so that it doesn't come in. Perfect. Okay, is he stable?
Yep.
He's on a sinus rhythm tachycardic as his oxygenation is good. He's got a CO2 trace quite nicely there, therefore his airway is in place. So nothing much has changed hugely. We need to keep a very close eye on his oxygenation for the next hour or so. Sometimes we do see very rapid deoxygenation after putting a patient on supine, and we should be prepared then to prone him again very quickly if that were to happen. So far he is stable, and we are very happy. Any other question, anything that you have noticed that needs to be discussed?
No.
You're all happy?
Yeah.
Yep.
Okay. Thanks very much, team.
Thank
So
you.
we need to come back and prone him again when the time.
Please prone patients when needed. It is very much possible to do without difficulty with small amount of practice. It will save more lives.